Then in terms of the investigation, again, another autosomal dominant inherited condition, you have to do the FGFR1, FGFR2 gene targeted testing. Invasive testing is required to make the diagnosis, amniocentesis. Prognosis, type 1 is a favorable prognosis with normal intelligence, while type 2 is poor neurological prognosis. Then the dystrophic dysplasia. Prevalence 1 in 500,000, very rare. The phenotypic expression varies. The character features include severe shortening and the bowing of all long bones, multiple joint flexion contractures, and scoliosis. Clubfoot, abducted position of the thumbs, referred to as hitchhiker thumb, where the hitchhiker who are trying to stop to get a lift to somewhere, you use your thumb. So that's the hitchhiker kind of position. Associated abnormalities include micronathia, cleft palate, thickened, deformed cauliflower ears. Detailed ultrasound scan examination is required. Dystrophic dysplasias is one of the skeletal abnormalities caused by mutations in the SLC2CA2 gene. Then the follow-up should be standard, and standard obstetric care and delivery should be in a tertiary cell. The disease is not lethal, and the neurodevelopment is normal. The long-term medical problems include short stature, progressive scoliosis, and joint deformities making it difficult to walk. Autosomal, in the case of recurrence, in cases where it is autosomal recessive, again, 25% chance of recurrence. Ellis-Van Creveld syndrome occurs in about 1 in 100,000, which again is rare in fetal medicine terms. In this condition, we have acromegalia and mesomelia, which is shortening of limbs, and post-axial polydactyly, narrow chest, ectodermal dysplasia, and heart defects. Some of these terms like acromegalia, mesomelia, we explained them in the presentation earlier on when we were defining specific terms. So even things like post-axial polydactyly, we explained all these terms. So you are more than welcome to just visit the old presentation to understand more what is acromegalia, mesomelia. Then the associated abnormalities, heart defects are present in more than 50% of the cases. There may be a single atrium with a large ASD, arterial septal defect, and aortic atresia or hypoplastic ascending aorta, and a hypoplastic left ventricle. Detailed ultrasound scan examination is required. It is caused by mutations in the EVC and EVC2 gene. Follow-up should be standard. Standard obstetric care and delivery should be in a tertiary center. Prognosis, neonatal mortality, 50% due to pulmonary hypoplasia and cardiac problems. The overall prognosis Sorry, I don't know how I got muted. Was I muted from the word go? Let's see. Sorry about this, guys. Okay, so I lost sound at 23 past 8. So let me see what I didn't mention that I can. Okay, I just lost sound just now. All right, great. So the sound is back now. I think the sound should be back on your side, guys. Sorry about this. I didn't realize. So the limb deficiency or amputations is where we are now. It occurs in about 1 in 20,000, which is fairly common in fetal medicine terms. In 50% of the cases, there are transverse reduction deficiencies of one forearm or hand without associated anomalies. In the other 50% of the cases, there are multiple reduction deficiencies, and in 25% of these, there are additional anomalies of the internal organs or craniofacial structures. Amputation of the upper extremity is usually an isolated anomaly, whereas amputation of the leg or bilateral amputations of all limbs are usually part of a genetic syndrome. Isolated amputation of an extremity can be due to amniotic band syndrome, exposure to a teratogen, or a vascular accident. If the defect is unilateral, it may correspond to the femur, fibula, ulna, or femur tibia radius complex. The femur is non-familial, while the second has a strong genetic component. So the former is non-familial. The former means the femur to fibula ulna kind of defect is non-familial, while the second, which involves the femur, tibia, and radius complex, is a strong genetic component, and hence a genetic tree may need to be constructed for the purpose of counseling and also explaining issues to the patient. Focomelia, hands and feet are present, may be normal or abnormal, but the intervening arms and legs are missing. So that's focomelia. I think we had a case, it should be Sally, I don't know, Paranyatua, of focomelia, where there are no long bones. We only have the feet attached to the trunk and also the hands. 3 syndromes must be considered in the differential diagnosis of focomelia. We have Roberts syndrome, which is autosomal recessive, where we have tetrafocomelia. Tetrafocomelia means all the 4 extremities are missing, except the hands and the feet. In addition, in Roberts syndrome, there will be bilateral fascial cleft, micrognathia, hypertelorism, ear and nose malformations. Then we have thrombocytopenia with absent radius syndrome. In this condition, it is an autosomal recessive. There is absence of radius bilaterally associated with thrombocytopenia. Then we have Graves syndrome. In this syndrome, it's an autosomal recessive disorder described in the inbred Indian tribes of Brazil, characterized by marked hypomelia of upper and lower limbs, increasing severity from proximal to distal. In contrast to Roberts syndrome, the lower limbs are more affected than the upper extremities. Congenital short femur. These are classified into 5 groups. The simple hypoplasia of the femur, short femur with angulated shaft, short femur with coxa vara. This is the most common due to deformity of the hip, whereby the angle between the head and the shaft of the femur is reduced to less than 120 degrees. There is absent or defective proximal femur, absent or rudimentary femur. So these are the 5 groups in which the congenital short femur can be grouped into. So it could be either just hypoplastic, or it could be angulated. Then it could be with coxavara, and it could also be the absent or defective proximal femur and absent or rudimentary femur. So all these are defects of the femur. One or both femurs can be affected, but the right one is more frequently involved. In femoral hypoplasia, unusual facies syndrome, which is sporadic, consists of bilateral femoral hypoplasia and fascial defects, including short nose with broad tip, long philtrum, and micrognathian cleft lip. This is why it is important to check everything on the baby. Whenever one defect is picked up, it is imperative to look for other defects so that we can arrive at this syndromic wake-up. Amniotic bend syndrome occurs in about 1 in 1,200. Okay. These are a spectrum of features involving extremities, craniofacial region, and trunk, which may be isolated or appear in combination. Demonstration of bends is not necessary for the diagnosis of amniotic bend syndrome. Extremities, they are absent digits or portions of the limbs, swollen distal arms, or leg resulting from constrictive amniotic bends. This is why it is important to nicely trace all the extremities. When you are looking at the extremities, it is not just the bone part which you are looking at, you are also looking at the tissue part to make sure that there are no indentations on the tissue. In the fascial region, we may see fascial defects, asymmetric microphthalmia, severe nasal deformity, and encephalocele. So all these syndromes, or all these features, the abnormalities are part of the amniotic bend syndrome. On the trunk, there may be severe spinal deformities, large abdominal wall defects with herniated intestine. The most extreme manifestation is body stalk anomaly. I think body stalk anomaly, we've also come across it, and we know it's a lethal condition. By now, I think we've all come across a body anomaly, because we have seen quite a number in our units. The incidence of chromosome abnormalities or genetic syndrome is not increased. Detailed ultrasound scan examination is important. Then ultrasound scan every 2 to 3 to assess the evolution of the condition. This does not apply to body stalk anomaly. Remember, body stalk anomaly is lethal. We're talking of a situation whereby just the extremities are affected and we are not having a severe kind of malformation. In a few cases, in terms of therapy, fetoscopic lysis of the bends has been used in case of constriction of the umbilical cord or a threatened limb amputation. Delivery, hospitals in neonatal intensive care and facilities for pediatric surgery. Prognosis and treatment depends on the nature of amniotic bend syndrome and the severity of deformation. Partial deformities often require extensive reconstruction procedures, and body stalk anomaly is lethal. No increased risk of recurrence. Arthrogryposis. Fairly common. I think we've seen quite a number of cases, both in the private and the public sector. I think we've seen 4 to 5 cases now. So less common is 1 in 3,000. This is a malposition of the limbs and limited fetal movements resulting from contractures in more than 2 joints. The onset of the arthrogryposis varies from 12 to 30 weeks of gestation. The condition is commonly associated with polyadamnios after 25 weeks of gestation. It is also associated with a narrow chest, micronathia, and knockout edema. Knockout translucency may be increased at 11 to 13 weeks for these babies. So remember, it's not just downs that increase knockout fold thickness or knockout translucency. There are also skeletal dysplasias that may give us an increased knockout translucency. Then fixed abnormal contractures of muscles can be regional or generalized. When they are regional, only the lower and the upper limbs are affected. If the lower region is affected, the legs are hyperextended and crossed. If the upper region is affected, the arms are flexed, lying on each side of the thorax. Then in generalized, all muscles are affected, as in fetal akinesia deformation sequence, which I will describe just now. The chromosome abnormalities, there are few cases that have trisomy 8 or trisomy 18. More than 150 genetic syndromes associated with arthrogryposis. The most common ones are fetal akinesia deformation sequence. This is a group of abnormalities of different causes characterized by decreased fetal movements, multiple joint contractures, fetal growth restriction, fascial anomalies, pulmonary hypoplasia, and occasionally height drops. Then we have cerebral oculofascial skeletal syndrome. This is an autosomal recessive where they severely reduce muscle tone, distinctive facial features, low set ears, microthymia, micrognathia, and abnormalities of the skull, limbs, heart, and kidneys. Then Null-Laxova syndrome is an autosomal recessive where there's hypertelorism, macrocephaly, agenesis of corpus callosum, contractures in the upper and lower limbs, and fetal growth restriction. Then we have multiple pterygium syndrome, which is an autosomal recessive condition where we have cystic hygroma, contractures in all joints, microcephaly, and micronathia. So be aware that when we are dealing with contractures that involve the joints, there are certain sequences and syndromes that may be underlying, and hence it is important to check the other features. Investigation, detailed ultrasound scanning investigation is required, and karyotype and chromosome microarray is necessary. For those who are not aware what chromosome microarray is, please go to our YouTube channel and watch our talk on prenatal diagnostics tests. I think we did this talk last year, so you can find it there. And of course, if you want the explanation of what conventional karyotype is, you can also go there and listen. Detailed medical history should be obtained containing infection, fever, or hypothermia, and exposure to teratogens such as phenytoin and ethanol. Myotonic dystrophy or myasthenia gravis should be ruled out. Ultrasound scan every 2 to 3 weeks to monitor growth, movements in all joints and amniotic fluid volume. Amniotic drainage may be necessary if there is polyadamnios and shortening. So this is how the limbs look in arthrogryposis. You can see that there is an hyperextension here. We are seeing on this baby. So it's part of the if this was a baby, this baby had deflection and deformity of the elbow. These are not the diagnoses you just make on quick eyeballing. You need to look at the baby enough. Sometimes you may know you have to look at the baby more than once for you to be certain, because babies tend to pose in this kind of way, even if they are normal. So unless, of course, if you see this, but this is not a normal position, as you can see that this is the anterior part of the thigh, and this is the posterior. Look how the knee joint is positioned here. So, but this kind of position is a tricky one. Do not rush to say there's flesh and deformity at the elbow. Give this baby enough time to move before you make conclusions. If you are not certain, you may ask the woman to come back again another day. Certainly, the baby will have to show you different position if there is no arthrogryposis. So be careful in making the diagnosis, unless if there are other obvious features, like in this case where you saw that that knee joint is not in a normal position. Prognosis. The delivery should be in intensive care. C-section is required because of the difficulties. These joints will not be easily manipulable to come through the vagina. So as a result, there may be issues here for this baby to fit into the pelvis. So C-section is recommended. If multiple organs are affected, because respiratory muscles may also be affected, the baby may not be able to breathe. In this case, the mortality is very high. So that most babies die within the first few months of life. If only limbs are affected, surgery and physiotherapy aim to achieve the maximum function for each involved joint. So there may be room for physio here. Then the recurrence depends on the underlying condition. Distal arthrogryposis occurs in about 50% of the cases. Clinodactyly occurs in 1 in 100 babies, fairly common. This is a medial deviation or radial curving of the fingers at the distal interphalangeal joint, usually affecting the 5th finger. Like we said the other day, that it is a marker, one of the secondary markers for Downs we check for at the anomaly scan for women who have not been screened by NIPT or whose risk was borderline or intermediate. Chromosome abnormalities is found in about 60% of newborns with trisomy 21. The condition is usually isolated. That means it could occur in babies without trisomy 21. Detailed ultrasound scan examination is required, and invasive testing and array is recommended in 9 isolated cases. Follow-up is standard and standard obstetric care. In isolated cases, the prognosis is good. There's no need for surgery, just a slight malformation of the last finger, the little finger. In isolated familial cases, recurrence is 50%. As part of trisomy 21 is about 1%. Clubfoot. By now, we've all seen clubfoot, I suppose. It occurs in about 1 in 1,000 births. It's bilateral in 50% of the cases. In terms of the diagnosis, we have to demonstrate that the sole of the foot is not perpendicular to the lower leg bones. In greater than 50% of the condition is isolated. However, it is also associated with trisomy 18 and 13. It can be associated with chromosomal with prolonged but not chromosomal, but with prolonged oligodymnous brain abnormalities such as spina bifida, such as Arnold-Chiari malformation. Then is it Arnold-Chiari? Then also spina bifida, skeletal, and neuromuscular disorders. in more than 250 more than 250 genetic syndrome include Clubfoot as one of the defects. Ultrasound scan is needed as part of the investigations and also invasive testing. Follow-up is standard, and obstetric management and delivery is standard as well. The prognosis is generally good, but the babies will need physiotherapy and sometimes surgical correction. In 90% of the cases, good long-term function is achieved by manipulation and serial application of casts supported by limited operative intervention. Surgery is necessary in about 10% of the cases. In 1/3, more than one operation is needed. Recurrence, if one sibling has Clubfoot, it is 3%. If a parent and one child with Clubfoot, 25% recurrence risk. Club hands, not common when compared to Clubfoot, occurs in about 1 in 30,000. I think we have 1 or 2 cases we suspected we have clubbed hands. It's bilateral in 50% of the cases. They are subdivided into 2, the radial and the ulnar. Radial club hand is radial hypoplasia and acute radial deviation of the hand and absent or hypoplastic thumb. This is why counting the fingers is very important when you are doing ultrasound. Learn to count the fingers. Nothing is easy, but everything can be learned. So then we have ulnar club hands. This ranges from mild deviation of the hand on the ulnar side of the forearm to complete absence of the ulnar. Long bones have to be checked for their presence. Detailed ultrasound scanning examination is required, then invasive testing for karyotype and chromosome microarray. Follow-up scans every 4 weeks. Then in families with dystrophic syndrome, codescendation for the diagnosis of hematological abnormalities. The standard care is to be given. Then in terms of prognosis, depends on the associated condition. In isolated cases, the prognosis is good, but the babies will need physiotherapy and sometimes surgical correction to allow proper mobility. Recurrence risk, part of trisomy is 1%, part of genetic syndrome, 25 to 50%. Where are we with our time? I think I can still do Ectrodactyly. Occurs in 1 in 20,000. The spectrum of hand and foot defects with missing digits. So it is a spectrum where we have some missing digits. We could have a median cleft and fusion of the remaining digits, resulting in claw-like extremities. Chromosome abnormalities. This can occur in trisomy 18. The high incidence of genetic syndromes, there's a high incidence of genetic syndromes in this condition, with the common being Roberts syndrome. I think that we have already discussed this condition, Roberts syndrome, where we say there's Ectrodactyly. I know some of you wonder what is this Ectrodactyly. So we're saying they are missing fingers, missing digits on the palm. They are missing digits. And focomelia and also fascial cleft occurs in Roberts syndrome. Then we have ectrodactyly, ectodermal dysplasia. This is autosomal dominant, where there are deformities shown about the spelling of all 4 extremities, but more severe in the hands, and ectodermal defects, dry skin, sparse hair, dental defects, and defects of the tear ducts. This is not visualized by ultrasound. It's a postnatal diagnosis. We have the Naga syndrome, whereby it's an autosomal dominant condition, but in most cases, it's a de novo mutation. Ectrodactyly, micronathia, and external ear abnormalities. Split hand and foot malformation. There's ectrodactyly presenting as lobster claw anomaly. You know a lobster, right? Lobster claw. Detailed ultrasound scan examination is required, and karyotype and chromosome microarray is necessary. Then consultation by genetic clinical geneticist is required. Standard delivery in isolated cases is good prognosis. In surgical treatment, the physiotherapy reduces functional impairment of the hands. Recurrence is about 50% in familiar cases. I think we've already covered this. I think this is just a repetition, or it's me who went back. Polydactyly occurs in 1 in 100 in blacks and 1 in 700 in whites. More common in males than in females, 2:1. Probably all of us, we may have somebody with polydactyly in our tribe, right? Can that be correct? I think so. It could be that we have somebody with polydactyly in our families, because it's fairly common, 1 in 100. More than 5 digits with or without bony phalanx in the hand or a foot. So there are 2 types of polydactyly. The post-axial, which is more common. So the 6th digit is on the ulnar side or fibular side, after the 5th finger, 5th digit, where the little finger is. That's where the extra finger is. This is very common. Like I was saying, that most of us may have them in our tribe, but the thing is that it is removed after birth in most cases. So we don't get to see it in adults, but you know, it's very common. The pre-axial, this one is rare. The 6th digit is on the radial or tibial side before the thumb or before the big toe, if it is on the foot. Chromosome abnormalities are found in 75% of fetus with trisomy 13. That's where polydactyly is common. Very important for students. Remember this, it's an MCQ. Say which chromosome abnormality is likely associated with polydactyly. So in most cases, it is an isolated finding with an autosomal dominant mode of inheritance. In some cases, there's an association with genetic syndromes, such as Merkel-Gruber syndrome, which is an autosomal recessive condition with polydactyly, polycystic kidneys, and occipital cephalocele, Merkel-Gruber syndrome. Then we have Bardet-Biedl syndrome. It's an autosomal recessive with post-axial polydactyly, enlarged hyperechogenic kidneys, and postnatally, there's obesity, retinopathy, hypogonadism, and neurological disorders. Then we have short rib polydactyly syndrome. Again, another autosomal recessive with short limbs, hypoplastic thorax, polydactyly, heart and brain defects, and polycystic kidneys. Then we have the Ellis-Van Creveld syndrome. We've already described it, which is an autosomal recessive with short limbs, post-axial polydactyly, narrow chest, and heart defects. Detailed ultrasound scan examination is required and invasive tests in the array in non-isolated cases. Consultation with the clinical geneticist is highly recommended. In isolated cases, follow-up should be standard. Prognosis is good. Standard obstetric care and delivery is recommended. Recurrence risk, when there is a familial pattern, 50%. Part of trisomy is 1%, and part of autosomal recessive syndrome is 25%. Syndactyly, I think because of time, I will stop here. Then we can finish this next week when we finish the skeletal dysplasias. How many slides are left? Let me just see if we can finish. Because, how many slides to go? I think I'm left with 3 slides. So allow me to finish because this is the end of the fetal anomaly series. So I think we can't gather for 3 slides next week. Syndactyly occurs in about 1 in 3,000 pregnancies. 2 or more digits are fused together, bone or soft tissue. Chromosome abnormality, common finding in triploidy. Remember this, Syndactyly in triploidy. I think our colleagues, the general surgeon, called them webbed fingers, right? The webbed fingers. In most cases, it is an isolated finding, but there's a common association with genetic syndromes, such as Apert syndrome, which is autosomal dominant with the brachy, Syndactyly of hands and feet, craniosynostosis, hypertelorism, and heart defects. Then we have Carpenter syndrome, which is an autosomal recessive polysyndactyly craniosynostosis. Then the Fraser syndrome, again, it's an autosomal recessive microthermia, fascial cleft, then tracheal atresia, bilateral renal agenesis, and heart defects, and syndactyly or polydactyly. So that's Fraser syndrome. So you have Apert syndrome, Carpenter syndrome, and Fraser syndrome. Detailed ultrasound scan examination required, and follow-up should be standard obstetric care and delivery. Prognosis is good. In isolated familial polysyndactyly, the recurrence risk is 50%. As part of Apert syndrome, again, 50% because of the autosomal dominant pattern. Part of Carpenter and Fraser because of the autosomal recessive, 25%. Part of triploidy, no increased risk. So, yeah, I think this is the end of the skeletal dysplasia series. It's a very long presentation, to be honest with you, and a little bit complex to understand, but the only way to learn is to do things over and over again. This is why we post our presentation on YouTube, so that people can listen over and over again in their own free space. That way you can know. So we are done with the fetal anomaly series. It has been a very long 4 months, I think 4 to 5 months, but this is what it is. In other words, we have finished. I think we did preeclampsia screening at some point if you check in our notes. So we have finished all the fetal medicine modules. The multiple pregnancy module, it is there because we have been presenting the multiple pregnancy sessions for a very long time. Dr. Andagura has been presenting multiple pregnancy. I don't know since when. And all the videos are available on our YouTube channel. We have also done the first trimester, the aneuploid screening module. Again, it is there on the YouTube channel. We have been presenting a lot of first trimester stuff for everyone's learning. We have done Dopplers. Everybody now knows about Dopplers, the growth assessment. We did all that, the overgrowth syndromes. So we have finished the fetal medicine modules. We wanted to finish, and they are all available on the YouTube channel for people to watch. We will encourage everyone to go to the Fetal Medicine Foundation .com, the Fetal Medicine Foundation Global website, and complete, show the evidence of having completed the courses there. Very important. To get the certificates of completion of the theory session. We know you're already scanning, you already have vast experience of scanning babies now, but we need the theoretical background of what we are doing so that you can be able to talk to patients more effectively, and also so that you can be confident with yourself, because the theory will give you the basis of your confidence. Because people ask you certain questions like the prognosis, all these issues. If you haven't read or if you don't have the theoretical background, you won't be confident enough to talk to patients. Otherwise, all the best. I think the future presentations will be now case-based. Any future fetal medicine people, they will not have this kind of session. All they have to do is to go on our YouTube channel and listen while we do case-based discussions. Otherwise, thank you so much for your time. Bye-bye. See you next week.